Surgical GI disorders in children. First of all is idiopathic hypertrophic pyloric stenosis. Pathology. It is the hypertrophy of the circular muscles in pylorus which causes obstruction stenosis. Association. Most common it is seen in firstborn male child and with erythromycin usage. Clinical features. Onset is more than 3 weeks after birth. Clinical features: vomiting, characteristic non-bilious and projectile. Epigastric swelling, usually following episode of vomiting, and it is an olive-shaped swelling. Visible gastric peristalsis. Increased peristaltic activity to overcome obstruction. Direction is from the left to right, seen after feeding. Dehydration and electrolyte imbalances. Due to chronic vomiting, milk feeds hydrogen ion, chloride ion, potassium ions. It can cause hypokalemic, hypochloremic, metabolic alkalosis. If there is no treatment, then sodium ion lost through vomitus, kidney reabsorbs sodium and secretes potassium. Depletion of potassium and secretion of H plus ions, hydrogen ions, into urine instead. This will cause paradoxical aciduria. Investigation. You do an ultrasound, which is the investigation of choice, and you will see pyloric muscle wall thickness is more than equal to 4 mm. You will see that pyloric muscle wall thickness is more than equal to 4 mm, and pyloric channel length is more than equal to 16 mm, and pyloric channel length is more than equal to 16 mm. That's the ultrasound. Barium contrast X-ray. Not commonly used. You can see narrowing of pyloric channel. You visualize that as a string sign. Management. Correction of dehydration. IV fluid used. Half normal saline plus potassium plus 5% dextrose. How do you correct the dehydration? You use IV fluids and you use half normal saline plus potassium plus 5% dextrose. It corrects hypocalcemia, hypokalemia, hypoglycemia, fluid loss. Step 2 is surgical treatment, Ramsted's pyloromyotomy. Ramsted's pyloromyotomy. Duodenal atresia, most common type of intestinal atresia. Pathology. Failure of recanalization of duodenal lumen. Duodenal atresia, which is the most common type of intestinal atresia. Pathology. Failure of recanalization of duodenal lumen. Association. It is associated with Down syndrome and it is seen in approximately 30% of babies in Down syndrome. What is seen in 30% of babies with Down syndrome? Which intestinal atresia? It is duodenal atresia. Clinical features. Polyhydramnios. That is the clinical feature. Polyhydramnios. So antenatal difficulty in swallowing of amniotic fluid, that is the reason, and bilious vomiting soon after birth. Types. Duodenal atresia, it's type 1, type 2 and type 3. Type 1 is most common in where you have a mucosal web, Windsock deformity, no complete obstruction, but it's a Windsock deformity, type 1. Type 2, arthritic ends of duodenum, atretic ends, fibrous band, atretic ends connected by a fibrous band. Type 3, disconnected atretic ends gap present between atretic ends between complete atresia. That's the type 3. So type 1 you have a incomplete mucosal web, type 2 you have a fibrous band, and type 3 you have nothing but a gap. That's your duodenal atresia. Now investigations. So X-ray, you see double bubble sign, also seen in annular pancreas, obstruction due to part of pancreas surrounding the duodenum. So you see double bubble sign, which is obstruction due to part of pancreas surrounding the Duodenum, also seen in annular pancreas. So this is the duodenum, this is the stomach, and this is the double bubble sign. Ultrasound CT scan. This is the investigation of choice. Atresia is distinctly seen. Ultrasound or CT scan is the investigation of choice, as atresia is distinctly seen. Treatment: duodenostomy. Atretic ends of duodenum is connected. Duodenostomy. Atretic ends of duodenum is connected. Preferred method: decreased risk of post surgery complications like anastomotic leakage. Duodenostomy. Atretic ends of duodenum is connected. Preferred method: decreased risk of post surgery complications like anastomotic leakage. Preferred method is decreased risk of post surgery complications like anastomotic leakage. So that is what is the preferred method: duodenostomy. Duodenojejunectomy. Atric ends of duodenum connected to jejunum. That is duodenojejunectomy. Intussusception. Intussusception is the most common cause of intestinal obstruction in 5 months to 3 years. So intussusception is the most common cause of intestinal obstruction between 5 months to 3 years. Most common cause of abdominal emergency in children. Less than 2 years. So, most common cause of abdominal emergency in children less than 2 years is intestinal intussusception. Pathology: so telescoping of one part of intestine into another causing obstruction. Most common site is ileocolic junction. Intussusception usually proximal intussuscipiens, usually distal. So the one which is getting inserted is the intussusceptum, and the one which is receiving is the intussuscipium, and this is the lead point. Most common site is ileocolic junction. Ileocolic junction. Pathology: pathogenesis, complementary feeding, viral infection, vaccination, lead point mass formed. Less than 2 years, swollen pairs patches. More than 2 years, polyp or lipoma. Less than 2 years, pairs, patches, swollen lymph nodes. That's the most common cause. More than 2 years, polyp and lipoma are the common causes. Telescoping of intestinal mesentery over it. Obstruction to venous return, edema of bowel and bleeding of mucosa. If untreated, necrosis and perforation of bowel. Clinical features, age of onset less than 2 years, usually around 6 months due to complementary feeding, seen in previously well fed child. Triads are seen in this condition. So, age of onset is less than 2 years, usually around 6 months due to complementary foods, seen in previously well fed child. Triads seen are abdominal pain, right upper quadrant mass, and vomiting, and current jelly stools. So, most common in 90% of patients, you see uh, abdominal pain, which is and right upper quadrant mass and vomiting. Abdominal pain is paroxysmal colicky pain with knees drawn to chest. Right upper quadrant mask is due to telescoping, right upper quadrant, and vomiting. This is the 90% of scenario. Classic to 30% of patient has abdominal pain, right upper quadrant mask, and current jelly stools, which is mucus plus blood. So mucus plus blood, they have current jelly stools. PPV 100% positive predictive value. So this 90% PPV for this triad, pain, vomiting, mass. 30% PPV for this triad, pain, current jelly stools, mass. If all are seen, then 100% positive predictive value. Investigation, ultrasound. Investigation of choice is ultrasound. Longitudinal image. Telescoping is seen. Transverse image, donut sign due to intussusceptum seen inside intussussapiens. So longitudinal, you see telescoping, and transverse, you see donut sign due to intussusceptum seen inside the intussussapiens. Color Doppler, done to assess vascularity of affected tissue. Color Doppler is done to assess vascularity of affected tissue. Barium contrast enema, rarely done. Claw sign seen at the sign of intussusception. Barium contrast enema, rarely done. Claw sign seen at the sign of intussusception. Treatment. Early recognition of intussusception is important. Child presents with intussusception, keep child nil per oral, nasogastric decompensation given, only IV fluids, parental nutrition, ultrasounded guided reduction, hydrostatic with saline, contrast not preferred with contrast medium, but contrast is not preferred. Aerostat safest, which is with air. So you do a USG guided reduction. Overnight observation, 10 to 20% have immediate reoccurrence rate, and then surgical reduction. Hirschsprung disease. Pathology. Failure of migration of neurons from neural crest. Failure of migration from neurons from neural crest. Aganglionosis in submucosal or myenteric plexus. Aganglionosis in submucosal and myenteric plexus. Most common site affected is rectum more than sigmoid colon. Most common sign affected is rectum more than sigmoid colon. Most common site affected in Hirschsprung disease is rectum more than sigmoid. Most common association is gastric association in Down syndrome. Most common gastric association in Down syndrome. Consequences. Aganglionosis, which affects intestinal motility, peristalsis, sustained contraction with no relaxation due to nerve fibers due to absent ganglions, narrowing of intestine, most common it is in rectum, most common cause of congenital motility disorder, most common cause of lower intestinal obstruction in infancy. So it is most common cause of congenital motility disorder, most common cause of lower intestinal obstruction in infancy. Clinical features: delayed passage of meconium in more than 48 hours. Delayed passage of meconium more than 48 hours. Abdominal distension. On per rectal examination, anal sphincter is normal and lumen is narrow. What are the clinical features? The passage of in Hirschsprung disease, the passage of meconium will be after 2 days. There will be abdominal distension. On PR examination, anal sphincter will be normal. There will be normal tone, but the lumen will be very narrow. On removal of finger, sudden expulsion of meconium due to transient dilatation. Investigation, radiology, plain X-ray, decrease absent air in the pelvis. So when you do a plain X-ray of abdomen, you'll see less air or no air in the abdomen pelvis. Barium contrast enema diagnostic. Segments may not always be visualized in barium contrast enema. Rectal manometry, absence of recto-anal inhibitory reflex, no decrease in anal tone on rectal dilatation. Absence of recto-anal inhibitory reflex, rare. Recto-anal inhibitory reflex. When you do a rectal manometry, then you see absence of recto-anal inhibitory reflex, rare. No decrease in anal tone on rectal dilatation. Rectal biopsy is the investigation of choice. There will be no ganglions, only nerve fibers. Nerve fibers will be hypertrophied due to lack of inhibitory effects from ganglions, and they stain with acetylcholine esterase. So when you do a biopsy of the anal wall, then you see no ganglions and you see nerve fibers, but the nerve fibers are hypertrophied due to lack of inhibitory effects from the ganglions, and they stain with acetylcholinesterase. In this diagram, you see full dilatation of normal segment due to meconium, transitional zone mildly dilated segment, narrowed rectal segment. Treatment: early presentation and delayed presentation. If there is an early presentation, pull through procedure, removal of affected segment. Unaffected proximal segment, pull through and attach to anus. That is the pull through procedure. Delayed presentation, constipation in an older child, colostomy, relieves obstruction, and then pull through procedure. You do pull through procedure. In the next video, we'll see airway malformation and foreign bodies.